first part, which I actually think it's the most important part because it is this morning section where I am going to try to provide you with the tools that you're going to apply to most clinical scenarios. And I say most clinical scenarios because as with any fields, we're going to encounter certain facilities, certain cases that is going to be very challenging to all of us, including us who have background in radiation therapy technology. But again, first part has a lot of slides. The other thing that I want to point out is that when I do my presentations, I like to provide the participants with a lot of reference material, a lot of stuff that when you have the time, you can go back, review it again, refer to it, and have it be very useful to you in your daily practice. I am a practicing tumor registrar. Okay, I actually abstract cases all day long, including a part-time job that I have abstracting. So I abstract tons of cases. As far as my radiation therapy background, I got my radiation therapy license in, 1999. And I practiced that for well over a decade as a practicing radiation therapist, and then I switched on as a director of schools of radiation therapy in New York City. So my responsibility was actually to train radiation therapists in 2-year programs, same program that I went through, a 2-year program. So I think I have a unique perspective because I know what CTRs go through every day. And I have the background in radiation therapy. So I know what it is that you're looking for, and I know the challenges that you face. So with that in mind, these are what I consider to be the key factors for abstracting radiation therapy treatments. And again, all of these boxes, A through E, reflect what we are required to code based on the STOR manual. And by the way, I was told that the STOR manual was going to be released early this month. I haven't checked yet. I haven't received any emails, but we should keep an eye on that. The official date that I was given was November 1st. All right, so number of phases, order of phases, the total dose summary, radiation therapy to the draining lymph nodes, and the primary treatment volume. I go into the forum from time to time looking for some of the challenging questions. And when I have the time, again, I have 12-hour workdays. When I have the time, I select some of those and I do respond to them. And then I still get emails from CTRs in the field. And, I could put the questions that I get right below any one of these boxes, because all of these pose challenges to us. How do we determine the number of phases? Once I have the number of phases, how do I order them in my abstract? And if I have more than one phase, now I have a lot of information on the dose. How do I total the doses? Should I ignore this? Should I ignore that? I'm getting these astronomical numbers. Do they make any sense? Radiation therapy to draining lymph nodes. Okay, it is unfortunate that when we look at the treatment summary, we are not always given the full picture, and that I don't believe that that's going to change anytime soon. So, with that in mind, I also have a few slides that hopefully will allow you to complete as best as you can that picture, so that we can look at these 5 boxes here and be able to determine how to code that information. And your primary treatment volume, okay? How do we determine that? So here's a clinical case that I'm going to be covering later this afternoon. This is case number 6, breast tangents. Okay? Right off the bat, tangents, That's the other thing about radiation therapy, that you get bombarded by terminology that nobody really has taken the time to decipher for you. Okay. Just like that, we are expected to understand that new language. Okay. It really is a foreign language. So here we go. Bullet number one, that's pretty much basic, the staging and the type of cancer that this patient has. Bullet number two is generally, two and three is what we get with treatment summary. And again, right now, there is no format, no uniform format that is used to present this information to us. When we look at the medical record, it could be a number of different formats that the radiation oncologist or that your facility uses to provide you with that information, or to enter that information into the medical record. So here we have a left breast tangents with 10x beam, 25 fractions. You have your date, you have the superclav, and again, 10x. And you have your boost. Again, here's another term on FOS, mini tangents, and so forth. So for somebody with radiation therapy experience, I look at this slide and this is how my eyes look at it. From my experience, what I have highlighted in red is what's going to help me code this particular case. Hopefully, by the end of today, you will have some of these tools where you can look at a treatment summary and also approximate this selective viewing of the information, so that you can extract only the most important things that will help us put the picture together, a full picture of what this case is all about. Okay. Why do I highlight lumpectomy? Okay. A lot of us would just fly by that term. Well, the lumpectomy it tells me, for example, that when I look at the primary treatment volume, that the breast is still there. Okay, so it tells me, for example, I should not even consider chest wall 42 as a code, because this patient just underwent a lumpectomy. Okay, so this is how we start arriving to what codes am I going to use. We can narrow down the codes. N1, when I see that this patient stage is N1, that tells me that this patient very likely is going to be treated to the lymph nodes. Okay. Remember, that's one of the last boxes in my first slide. RT to draining lymph nodes. 10x, that tells me something about the modality that was used in this case. Okay, that's very important. And it's in several places. Okay, 10x. Boost. Okay, we need to know what a boost is. We need to know, and there's another term that is used for that, CD, cone down, which I'm going to go over. On FOS, okay, all this information, to me, it means a lot. Okay. And then after I interpret this information, in my mind, I mean, I don't necessarily have to go through this and rewrite everything as I suggest here because of my experience. But in my mind, this is what I see when I look at. There are some facilities that actually give you the treatment summary in table format, which can be very useful as well. Okay, so in my mind, I look at it as a table format, and then at the moment I see the beam energy, it tells me the equipment that was used to deliver the radiation therapy treatment to this particular patient. And that tells me a lot about the codes that I should be looking at. Okay. Breast tangents, for example, and again, I'm going to go over this in greater detail. It tells me, again, a couple of things. It just tells me that a linear accelerator was used, and it just gives me an idea of the direction of that photon beam as it treats that patient. Okay. On FOS, I know that on FOS, from a radiation therapy perspective, just means that this patient was treated with electrons. Okay, I'm going to highlight that again further down the road. But anytime you see, and I have gotten these questions, how do I code on FOS? I'll go into detail, but it's electrons. Many tangents. So in this particular case, this patient received an electron boost and a photon boost. Not unusual, but most are one or the other. Okay? In most cases, what you're going to see is either just a photon boost entirely or an electron boost. Okay? And again, in the beam energy, it's telling me exactly what I just said here and what I just saw here. This is electron, this is photon, this is electron, E for electrons. And anytime we have NV or X, it tells me that it was photons, okay, in the photon mode. And that tells me, that gives me the information that I need to code the planning modality, okay. So starting with the basics, external beam radiation therapy. What does that mean? It means that the radiation that we are using to treat that patient is outside of the patient. The source is outside of the patient. That's all it means, external beam radiation therapy. It can be in photons, and this line is just the modality codes that you find in the store manual. 02 for photons, 03 for protons, and 04 for electrons. All of these are what we consider, what we call external beam radiotherapy or radiation therapy. So when we talk about code 2 for photons, what should we be looking for in the treatment summary? This is how these slides are going to be helpful to you. Anytime you look at the treatment summary and they tell you that, and they give you the beam energy, if they use these terms, NV, which stands for megavoltage, NVX also stands for megavoltage, X, same thing. All of these are telling you that it is photons, okay? Photons. So you see this as in these examples, immediately you have taken care of one of the code requirements for your case. The modality code should be photons, 02. Right away, out of the way, okay? NV, NVX, or X, photons. Protons. Most of us are not going to encounter proton therapy because I think there might be just 6 or 7 proton therapy facilities in the country. Okay, but if you are one of them, okay, the energy for proton therapy, or the unit, excuse me, is CGE, Cobalt Grade Equivalent. Okay. So you see that unit, you know that your facility is treating your patients with proton. Okay. Electrons, again, you go back to your treatment summary. If they refer to them as MeV or just simply E, you know that they're talking about electrons. Okay? The other item that you can add here to your slides, if you have it printed out, is I will just put in that term that I just discussed, the on FOS. If you see them describe that particular boost as on FOS, it's electron boost. The one thing that I always say in every one of my presentations is know your equipment. You have to know your equipment because be familiar with the equipment that your facility uses to deliver radiation therapy. Actually make a list of it. Once you have that, you can go back to my slides and you'll see that some of my slides will fit exactly with that equipment that your facility uses, and it will show you that these are the only options available to you based on that equipment, okay? Most facilities in the United States or even in the world still use the linear accelerator as the mainstay for delivering external beam radiation therapy. Okay? This is a typical look of a linear accelerator. There are, I believe there are 2 or 3 manufacturers. The newest ones are starting to look like the Star Trek type of futuristic looking equipment, but they're still linear accelerators and they still work the, basically the same way. Now, the older the other thing to know about these linear accelerators is one thing that I didn't, let me just get my laser pointer here. One thing that's missing in this picture is the treatment couch. The treatment couch will be extended right here. The photon beam will be exiting from the equipment through this window. This is an opening. These are the collimators, and there are actually some metallic leaves that we control. Actually, they are automatically controlled by the software that will open to the shape of the treatment volume that is going to be irradiated within the patient. So if your couch is here, your patient is over the couch, this gantry can rotate about the patient in 180 degrees in either direction. So you can treat from any direction from 0 to 360 degrees on this patient. The couch itself can also rotate. And of course, it can go in and out laterally to the right or to the left, and it can rotate about an axis point on the floor. Okay. There are lasers in that treatment room, and all those lasers, and including lasers in the machine, there are lasers on the ceiling, on each side of the wall, in that direction on that wall. All of them converge at a point in space. That point in space we call the isocenter. The machine is calibrated to rotate about that isocenter, and the distance from that isocenter or that point in space to the source of the radiation is 100 centimeters. Okay? So we put the patient relative to that isocenter. We move that patient, that couch, everything in that room relative to this isocenter. And this is just a schematic of the internal parts of a basic linear accelerator. We have here, this is the electron gun. And the electron gun just basically generates electrons that are accelerated through this cavity at nearly the speed of light. There is this enormous magnet that rotates that electron 270 degrees. So it goes, turns here, that's 90 degrees turn, another 90-degree turn, and another 90-degree turn in a downward direction, where we make that electron beam collide with a metallic solid object. We call that a target. In a linear accelerator, that solid object is a tungsten target. And in that violent collision, we convert the electron stream into photons. Inside the collimator is what we call the primary collimators, and these are static. We cannot control them. This limits the opening of the collimator to 40 by 40 centimeters. These are the secondary collimators that we can control with our software, and this is what shapes the beam as it is aimed at the patient. The one thing that I want to point out about the geometry of this beam, if you look at this here, is conical in shape, like a cone, okay? Cone down. Okay. I added these terms just last night, just to give you additional information. You might not have this in your slide, but cone down comes from this. The shape of the photon is like a cone. When you cone down, if you can just imagine, now the beam is much narrower. So at the bottom, it will be a very small circular or conical opening. That's cone down. You have taken a large cone and reduced the shape of that cone so that when this enters the patient or the depth where the tumor is, you are now irradiating a much smaller volume. That's what a cone down is. So equate cone down with a boost, and a boost is always targeting a very small volume, typically within your primary site, okay? And because it's a very small volume, we do not generally include the lymphatics because it's very small. So that's one thing to keep in mind. Again, as we start coding, is anytime you see a boost, in general, the boost is not targeting the lymphatics. Beam directions. A lot of times we see these abbreviations used, okay, that the patient was irradiated using an RAO, an LPO, AP, and a PA. This is just beam direction relative to the linear accelerator. This is the couch. Here's my patient. If the gantry is directly above the patient, the gantry is at 0 degree. That is what we call an AP direction, anterior, posterior. Now I'm going to rotate the gantry because this patient, according to the prescription, this patient is going to be treated with a PA as well. So I'm rotating the gantry 180 degrees until it is below the patient. That's a PA, posterior anterior. That's all it means. RAO, okay, right anterior oblique. LAO, left anterior oblique. LPO, left posterior oblique. RPO, right posterior oblique. It just gives you the beam direction. It has nothing to do with an actual code in the store manual. Okay. The only thing that one of the useful information that you can gather from this is that anytime you see this, you know that they're using a linear accelerator. So you're looking at external beam radiation therapy, most likely photons. Okay. And this is what I refer to the distance from the point source inside the gantry to that imaginary point where the lasers converge in that treatment room. It's 100 cm. That's how the machines are calibrated. And the central photon within that beam, that conical shaped beam, we call it the central axis. So here's your APPA. Okay, there's your patient. Excuse me. The other thing to keep in mind with photon therapy is that when I irradiate the patient from an anterior direction, this is your photon beam. The nature of photons, it's very penetrating, okay? This is my planned depth. This is where I want to deliver 100% of the dose. But that does not mean that all along the path of the photon, some dose is actually being deposited, okay? Even as it exits the patient. But what I want to point out here is your central axis. Look at your central axis. As it enters and as it exits, it overlaps with the central axis from the PA direction as well. This is what we call coplanar beams. Just in case, I've seen some treatment summaries that refer to these terms, so I just want you to know what they mean. And basically, it's not something that you should be concerned about as far as coding. But a coplanar beam just essentially means that the entry beam, the central axis overlaps with the central axis from the opposite direction, okay? And that means these have to be 180 degrees apart for these to overlap. Non-coplanar beams, and this is what we use most often in most treatment plans, means that you have multiple beams, and notice that your central axis of each of these beams do not overlap with each other. The importance of this for patient care is that you are reducing dose to healthy tissue. In this case, for example, with the coplanar beams, the AP is delivering those all along this path. And then the PA also delivers those all along the same path. So all of this region is getting double whammy, so to speak, as opposed to here, since they do not overlap, you are reducing exit dose. Another schematic, I already went over that, but this is Yep, this is your couch. This is how the patient is on the couch, and here's your isocenter. So we actually move that couch relative to that isocenter to set up our patient based on what the treatment depth is as per the plan. Okay, so treatment planning techniques associated with external beam radiotherapy. Okay, this row here are the modality codes. Okay, we went over that, the photons, protons, and electrons, 2, 3, and 4. This row here are the treatment planning techniques associated with each of these. So when you have a patient that is being treated with photons, these are the, now you have narrowed down your list of options for the planning technique when photons are used. So this is a very useful slide. You don't have to look at the whole range of options as long as you know your modality code. Okay. And notice if you go to electrons, you only have a few choices. The same thing with the proton. It is in the photon modality that you have a lot of other options. So it's a little bit more challenging. Okay. A little more on the external beam radiotherapy. And these are all the planning techniques. 2D planning technique is not used very often, okay? Especially if it's for curative intent. You're more likely to see 2D in palliative cases. If a patient has metastatic disease, let's say to the femur, okay? We also have to consider the anatomy of cancer, the anatomy of the location where bone mets may occur. If it occurs in the femur, for example, know that based on the anatomy, there really aren't any critical structures or radiosensitive structures that we should be that concerned about. So if a patient has an extremity bone mets, that's where you're more likely to see palliative radiation therapy using 2D plans. They might go APPA or just right lateral, left lateral, 180 degrees apart. So what you should be looking for in the treatment summary is if they refer to them as open fields. Okay? Open fields means that there is no 3D conformal planning in that case. For the 3D conformal, a few things to keep in mind. More than 95, or let me just say more than 90% of breast tangent cases in the United States that use external beam radiotherapy for these patients, they use 3D conformal plans. Okay, so one thing you might want to check with your facility is what is their policy for treating breast cases with external beam radiotherapy. And you're more likely to find that across the board, they're going to be using 3D conformal plans. Once you have that information, that's it. Any cases that come to you, any breast cancer cases that come to you from that particular facility who are getting external beam radiotherapy, you're going to code them to 3D. Okay. Other terms that they use for that is synonymous with 3D is field in field technique. Okay. Forward IMRT or static IMRT. Okay. Sometimes when we use these terms, our eyes immediately go to code 05, not necessarily. Okay. Very, very few institutions in the United States treat their breast tangents with IMRT. Most still use 3D conformal, which is sufficient for most cases. IMRT, intensity modulated radiation therapy. Now we're getting into the more complex treatment plans. Okay. Some of the terms that are associated with that is rotational therapy or arc therapy. Anytime you see rotational or arc therapy, at minimum, you should be looking at IMRT. You are beyond 3D. So anytime you see arc or rotational, skip this already, okay? You're looking at this, or excuse me, or even a higher stage, coding. And I'm going to go over this in more details, okay? VMAT, rapid arc, tomotherapy, all of these include rotational therapy. And in general, they're used with conventional fractionation, and I've given you the definition of conventional fractionation. If the prescription states that the patient is getting 180 to 200 centigrades per fraction over several weeks, that's conventional fractionation, as opposed to hypofractionation, where you see a patient come in for maybe 600, 800, or even 1200 centigrades for maybe 3 or up to 5 fractions. That's very short. That's a very condensed 1 to 2 weeks. That's what we call hypofractionation. And when you see hypofractionation, you have to start looking at stereotactic body radiation therapy. Excuse me. IORT for breast cancer cases. Here's my claim. This one slide is going to cover over 90% of all IORT breast cancer treatments in the world. Okay, if you understand this slide, you should be able to code IORT correctly moving forward. The one thing that you have to do on your part to make this true is you have to know the equipment that your facility uses. Okay. For example, my facility uses the Zeiss Intrabeam for all IORT cases. So what is my modality code at my facility when IORT is used? Here we go. This slide tells me, look up top, coded to O2, external beam photons. What is my planning technique for Zeiss Intrabeam? Well, go down here, and my planning technique is going to be O2, low energy X-ray photon therapy. That's it. I know how to code IORT. If your facility uses the soft accent, same thing, O2 and O2. If your facility has this type of equipment, all of these deliver electron therapy only, okay? So here's your modality code, your planning technique. If your facility uses any of these equipment, then there is your modality code, and here is your planning technique code. Pretty straightforward, but you have to know the equipment that's used at the facilities that you code for. All right, so let's go back to that original slide. So number of phases, order of phases, and so forth. Starting with the number of phases. What is going to affect the number of phases, or what's going to determine the number of phases? 4 factors. If there's a change in the target volume, change in the target site, that's pretty obvious, right? Changing the planning technique, and changing field size or modality. So any of them will result in a new phase. So let's look at each of these at a time. So number of phases. Change in target volume. When you have SIB, simultaneous integrated boost, and you typically see these a lot in head and neck cancer cases, you also can see these in prostate cases. So this is how typically the information is presented in the treatment summary. We talk about PTVs, PTV 70, PTV 63, PTV 54. Okay. A few things to keep in mind here is, number one, when we present this information in this format, we are telling you that the volume has changed. Okay. And look at the rule, change in target volume results in change in separate phases. So we have changed the target volume here 3 times. So that's 3 phases. Okay. And then there's a lot of more information that you can gather out of here. I mean, if you look at the energy, now we know NVX, that tells me that it's photons. So my modality code should be 0, 2 in this case. But back to the number of phases. This is clearly 3 phases because we have a change in target volume. How many changes in target volume? 3 of them. Another thing that I want to point out when there is simultaneous integrated boost, or other terms that we use is concurrent boost, is that these happen within the same time frame. Your start and end days for all of these are or should be the same if we're talking about SIB. And you can see that here, okay? Because when I put that patient on the treatment couch, I walk out of the room and I let the software take care of the rest, that is the treatment. All of these volumes are being irradiated that same day while that patient is on the treatment couch. That's what simultaneous integrated boost means. Change in target site. Okay, this is more straightforward. So you have a patient here with 2 metastatic sites, okay? The T-spine, L-spine, and the whole brain. Clearly, these are 2 separate sites. Okay? That's going to be a change in phases. So you have 2 phases. Changing planning technique. And again, these are real life case scenarios. Patient is being irradiated to the prostate using external beam radiotherapy, IMRT technique, and then followed by LDR brachytherapy. LDR because it's the iodine 125 seeds. Okay, we need to know the difference between what is an LDR radioactive seeds and what is an HDR. So iodine 125 is low dose rate, LDR. So these are clearly 2 separate treatment techniques. So when you have a change in the planning technique, you have separate phases. So in this case, 2 phases. The order of phases. Now, for any of you that have seen some of my previous presentations, there has been a revision to this one based on the CTR guide that we put together a couple of years back. So if the dose across a phase to a single point or region, okay, when you look at this, think of the more common case scenario that you're going to encounter or that you might be more familiar with. And that is, for example, at our facility, more than 30% of the cases that we treat are breast cancer cases. Okay, so what do we see? What are we more likely to see in those cases? The patient comes in for external beam radiotherapy. We treat the whole breast, and then the treatment summary will say that the patient was boosted with a photon boost or with an electron boost. Okay, but you're boosting the breast itself as well. So the primary treatment was to the whole breast, and the other boost was to a portion of the breast, within the breast. So if everything falls within that same volume, we can, number one, we can add, but in this case, we're talking about the order of phases. We just go by which happened first. And then just chronologically. If you have multiple sites, multiple metastatic sites, which can happen within the same time frame, then just put in the one that received the highest dose, okay? If you have the primary and metastatic site, this is the one that we revised, okay? My older slides will have that you will code the primary site first. But again, when we got together to revise the CTR manual, the guide, we decided, you know what, let's just keep it chronologically because that will just make it easier to keep that in mind. The overriding rule in the order of phases is chronologically. Most of the cases you're going to run into are either going to fall in, most of them are going to fall into this A category because a lot of the patients come in just for curative intent, okay? So we're not talking about metastatic sites yet. So just do it chronologically. But if you have primary and a metastatic sites, also chronologically. And then if you have the simultaneous integrated boost, remember, these happen at the same time every day. Start and end date for each of these phases is the same. So how do we order them? Just go with the highest PTV. Okay, highest PTB for SIB, simultaneous or concurrent boost. And this is the brief update that I was referring to when we make those changes. So example, the order of phases. Here's a prostate case. Notice this is a pretty large volume because it's treating the prostate and the nodes. But then the patient got an LDR treatment to a much smaller volume. It is still treating the prostate. So we just order them chronologically, okay? Which happened first. The prostate and the nodes were irradiated first, so that will be phase 1. And the LDR, interstitial brachytherapy, will be phase 2, chronologically. Multiple metastatic sites, same time frame, okay? Both of these, the T spine, the L spine, and the whole brain were irradiated on the same dates, same time frame. So how do we do it in that case? Well, rule B tells you start with the site with the highest dose, okay, which is the whole brain received 3,000 centigrays or 30 grays. There you go. That's phase 1. When you have primary and metastatic sites, again, just go chronologically. Okay, the patient was treated for brain mets and a right lung primary, okay, chronologically, which happened first. Simultaneous, go with the highest PTB. Highest PTB, 70. So phase 1 is PTB 70. Excuse me. Phase 2 is going to be PTB 63. And the smallest PTB is going to be the last one. Total dose, okay? Those across phases to a single point of region, just add them up. If you have multiple metastatic sites, please do not add them because it's not going to give us any useful data. Just select the highest dose. Whichever site received the highest dose, that's the only thing you code. When you have the primary and metastatic site, the emphasis is going to be on the primary site, and that's the only one that we're going to code the total dose on. Simultaneous, just go with the highest PTB. And then there was an update in 2019 regarding the brachytherapy dose. A lot of facilities are actually providing us with information, with total dose, brachytherapy dose that has been converted to an equivalent dose of in centigrades or in grays. If you're given that information, code that for that particular phase, okay? If it's not provided, then you use the 9999 for the total dose. However, this rule has not changed, okay? This rule was originally in the 2018 release of the STOR manual, and it hasn't changed, and it will not change for 2021. And that is, if you have one phase with external beam radiotherapy and another phase with brachytherapy, you cannot add those. You still have to use that 999999 with the 8 at the end. And let's just take a breather, okay? It's a lot of information that's provided to you. But again, you just, once this is over, you're just going to need to go back to it, take a look at your cases, take a look at the clinical scenarios that I'm going to present, and take a look at the guidelines that I've given you, the rules, and slowly but surely it should come together. But you have to have the list of the equipment that your facility uses. Total dose for brachytherapy, I'm just going back to that revision that was published in the brief. Okay? So if brachytherapy is the only mode of treatment, capture that when it's given to you, and when it's not given to you, use the unknown code. However, for this dose summary, if you have 2 different planning techniques, you still have to use this code. Total dose. Okay. Back to that example that we used before. You have a prostate seminal-vesicles and the prostate cone down. Okay, remember, this is a boost. Point to keep in mind is that both of these phases are targeting the prostate. Okay, this one, the prostate, and some additional volume, but nevertheless the prostate. And the cone down is the prostate. So when you have those to a single point, the prostate and the prostate, just add them. Okay, add these, and there's your total dose right there. Another example of the same. Okay, patient is getting irradiated to the bladder, and then the bladder is being boosted. That, as soon as I see the boost, it's telling me that it's a much smaller volume that is being irradiated. And typically, when a much smaller volume is being irradiated, it will be to a smaller total dose as well. But the point is, it is to the same site. So just add them to get your total dose. And for the breast, in both cases, in both phases, it is the breast. Different volumes, but it is nevertheless the breast that is the primary target for this external beam radiotherapy treatment. So rule number A tells us just add it and you get 6,000. Multiple metastatic sites. So total dose, because here you have an unfortunate patient with 3 metastatic sites, and each of them was given a different prescription. Okay? These are all palliative. So please do not add all of these to get the total. Follow the rule. Just select the highest dose site, which is 3,000. And that's what was captured in this abstract, 3,000. Again, multiple metastatic sites, highest dose. Okay, the ribs and the T12 spine. Highest dose is 1,600, and that's what we capture. Primary and metastatic site, this rule tells us that you only code the dose from the primary site. So here's an iliac bone mets, here's your primary site, and here's a spinal mets, okay? Prostate has a tendency to spread to the regional bone regions, okay? That would be the spine and portions of the pelvis. So as per the rule, we only capture the dose from the primary site, which is 6,000 centigrades. SIB, or concurrent boost. The rule tells us the highest PTV. Okay, so which is the highest PTV here? 6,600, and that's what we use. I mean, imagine if we were to add this, we're going to be getting an astronomical number that does not make any sense, and it will skew the data. Again, simultaneous integrated boost, SIB, go with the highest, okay, 7,000, and that's what was done in this case. If the brachytherapy is the only mode of treatment and the dose is given to you in centigrades, okay, so here we go, so SAVI catheter, and it tells you that it was in 34 grades was administered, okay, or 3,400 centigrades. And this was the only phase that was administered to this patient. So we will, again, so we can put that as a total dose as per rule E. And brachytherapy and external beam radiotherapy, okay? We see these a lot. A patient is getting external beam radiotherapy to the cervix. And the other thing that I want to point out in these cases is, and this is true also of the prostate, if this patient has an early stage cancer, and this is curative, clearly this is curative, this is not palliative, and you see that a patient came to your facility and got external beam radiotherapy in this range, okay, let me tell you, please make a mental note, for curative intent of early stage cervical cancer or early stage prostate cancer, 4,500 centigrade is not curative by itself. Okay, external beam with conventional fractionation. So anytime you see this, you should expect your patient to come back for a brachytherapy procedure, as in this case. So just as a side note, okay, this alone will not cure the patient. The patient will need a type of a boost, and this is the boost that's needed in this particular case. So here you have external beam radiotherapy and you have HDR brachytherapy. First of all, you have two phases, but because the planning technique is different, we cannot add them. So the total dose is going to be that code. But the total dose for this phase, you can capture that for that phase in the abstract as 2,400. You just cannot add them. IMRT or SBRT, this can be confusing. So let me highlight a couple of things that might help you in determining which one to lean towards. Okay. When IMRT is mentioned, you're going to consider IMRT if it's mentioned, first of all, and remember, don't just look for the initials IMRT, look for arc, look for rotational, look for VMAT. All of those mean IMRT as well. Okay. But in addition to that IMRT, you're looking at conventional fractionation. And again, you need to be familiar with what we mean by conventional or standard fractionation. Okay. And we do see this a lot in our daily practices. Patient was prescribed 180 centigrades times 28 fractions, or 200 centigrades times 25 fractions. The distinguishing traits of conventional fractionation is small fraction size within 180 to 200 centigrades per fraction, and a large number of fractions. We're talking 5 weeks, 6 weeks, 7, 8 weeks. Prostate cases could be 10, 12 weeks, okay? As opposed to hypofractionation, where you are limited to a few fractions and very large fraction size. I mean, I have seen 1,800 centigrades as a fraction size. So here's an example to illustrate that. So this patient received 200 centigrades in 30 fractions, total of 60, and using IMRT. Patient 2, 800 centigrades in 5 fractions, 6 NV IMRT. Okay, so both of them mention 6 NV IMRT. So 6 NV in both cases is going to tell me that this patient was irradiated using a linear accelerator, and also it's telling me that the modality code is 02 photons. Okay. Now, when we look at the planning technique, it's easy to just focus on IMRT and IMRT here. We also have to take it a step further too, and we need to consider the dose fractionation that was used. Okay. It's quite different between the two. A few fractions here, very large fraction size, large number of fractions, very small fraction size. Okay. If you dig deeper, you're going to find that this is most likely an SBRT, stereotactic body radiation therapy. And I will code it accordingly. RT to draining lymph nodes. A few points to keep in mind. Stereotactic body radiation. Thank you.
Mr. Wilson, we actually have 2 questions for you if you have time.
Yes.
So you saw my little plug for the time check for you, right?
Yes, I did.
All right, so the first question is, how do you code the date when phases are done on different dates?
All right. Don't get confused by that. The only thing that you should be looking at, especially if you have multiple phases, right? Um, excuse me. And we encounter a lot of cases like that where there are multiple phases, whether it's curative intent or whether it's palliative intent. All you look at is, when did your patient come into your facility for that first treatment? There's your start date. When did your patient finish the very last treatment of the very last phase? There is your end date. Okay. So let me give you a quick example. A patient comes into my facility and gets palliative radiation therapy for a lung primary to the spine. Okay. I'm just going to throw out these figures out at you. So the patient started on June 3rd for the spine, right? June 3rd, 10 fractions. So within 2 weeks, let's say June 15th, the patient finished that first phase. But the patient didn't come back for another month for the brain mets. Okay. So my patient started the brain mets, let's say August 1st, and finished August 16th for that brain mets. Those are two phases. My start day is the start day of the spine meds in June, and my end date is the end date of that brain meds in August. That's how you should look at them, even if there is a month or two interval in between, which is unusual, but it can happen. Okay. Prostate cases. Your patient finished the external beam radiotherapy to the prostate and maybe the spine, and maybe the lymph nodes, and we wait several weeks for that patient to come back for the seed implants. Okay, the end date for that patient is going to be when that patient came back for that seed implant. That's the end date, not when the patient finished the external beam radiotherapy, that 45 grays or so. Okay. For that prostate case, the patient just comes in for one session of brachytherapy. LDR, the patient comes in and we surgically insert a certain number of seeds into the prostate on that one day. That patient is kept under observation for overnight, but it's just that one day. And because they're permanent, that's it. So that is considered the end date for treatment for that particular case. Another question?
Yes, thank you so much for that. Yes, we do have another question. The other question is, good morning. For clarification on putting METs in the grid, when they do not to primary site, just MET site, we do not put METs in the grid. But when they treat primary site and metastatic sites, you only put highest MET in the grid? Question mark.
I'm not totally clear on the question, but if you are referring to the very last section that you just read, a primary and a metastatic site, there is one slide that covers that scenario. When your patient comes in for a primary and metastatic site, first of all, you're talking about two phases. Secondly, you only capture the dose from the primary site. Okay. You disregard the dose from the metastatic site. We cannot combine them. We cannot add a primary site dose to a metastatic site to get the total dose summary. No, only the primary site. If you have multiple metastatic sites, again, do not add them all up to get the total dose summary. When you have multiple primary metastatic sites, look at the highest dose delivered, and that's what you're going to code. Hopefully that answers the question. If not, maybe you can submit that in writing and I'll take a look at them.
Sure, sure. And then we do have one more question, which is AP/PA
Mhm.
and coplanar, are those always coded as 2D?
I get that question a lot. You know, uh, even in the NCRA conference that we just had recently, the radiation oncologist was asked that question, and the answer is, and you're not going to be happy about it, but the answer is it depends. um, as I said earlier when I referred to that, in the majority of cases, if an APPA technique is used, it's going to be for palliative intent. Look at the anatomy. That's going to tell you a lot also as to whether you're going to code it to um, 02 or 04. Okay. It's if it's in the extremities, okay? If it's on the head of the femur, if it's on the head of the humerus, if it's on the lower extremities, they're gonna most likely gonna use an APPA open field, and that's a 02. Okay? But if it's in a region where there are critical structures, well, imagine a patient that has that comes in for meds to the upper T spine. Okay, you have the esophagus, you have a portion of the heart, you have portion of the lungs possibly in that field. So in those cases, a lot of facilities for to reduce the dose to those critical structures, or as we call them, organs at risk, we are more likely to lean towards using either a 3D conformal plan or possibly even an IMRT, depending on the total dose that was prescribed to that patient. So, unfortunately, it's not that straightforward. But in the second part this afternoon, I'm gonna go over that as well and show you where you can look for additional information that will help you determine which code to use with APMP. Anything else?
That was it for now, Wilson.
Okay.
Correct.
All
Thank
right.
you.
Keep them coming.
Keep the questions coming.
Pick my brain. All right. Some of the key points with for radiation therapy to lymph nodes. Okay. This is very important, and this is also another area of confusion because we don't get enough information to guide us here. But these points will help you narrow down your options. Okay. SBRT, stereotactic body radiation therapy, or SART, synonymous, stereotactic ablative radiotherapy. What defines those two approaches is that you are treating a very small volume with a lot of dose, with a huge, I mean, the analogy that I use is, conventional radiotherapy, you're using a hammer. SBRT, you're using a very heavy sledgehammer, okay? But you are targeting a very small volume. Look at the size, 5 cm. You have seen me use a picture of 2 quarters next to each other. That's the approximate dimension of 5 cm. And that's about the limit of the volume that we use when we use SBRT or SART. Now, if you consider that size, that dimension, there is no way that we can possibly include regional lymphatics in such a small volume. So this is the easy part. If you have determined that that patient was actually indeed treated with SBRT, no lymphatics are being included in that phase. Okay. IORT, this is another easy one. IORT, you are also targeting a much smaller volume within the breast. It's partial breast. First of all, your primary treatment volume for IORT is going to be partial breast, 41. And because it is a much smaller volume, the lymph nodes are not irradiated. Okay, there you go with that one. Chest wall or lumpectomy, tumor bed or cavity boost. Okay. I mentioned earlier that you're more likely to see that boost for the chest wall, or more likely, especially for the lumpectomy cavity. Most of them are going to be photon boost. Some of them are going to be electron boost. For chest wall, you're more likely to see electron boost. The key thing is here that whether it is chest wall following a total mastectomy or the breast following a lumpectomy, it's a much smaller volume because this is a boost, a count down. So it does not include lymphatics. Okay. So boost, no lymphatics. SBRT, no lymphatics. IORT, no lymphatics. For pelvic sites, if the treatment summary does include or does mention the pelvis or the whole pelvis, then we can assume that the regional lymph nodes are being irradiated within that volume as well. So in that case, you will have to code the pelvic nodes 06. Interstitial or intracavitary brachytherapy. Think of these also as boost if it helps you to keep these in mind as far as whether the lymph nodes are included or not. As I mentioned earlier, boost, no lymph nodes. So think of interstitial or intracavitary brachytherapy, whether they are HDR or LDR, think of them as boost, no lymph nodes. Okay. So that will take care of most of the cases. Your primary treatment volume, and there's a reason why I included in parentheses the years 2018 and 2020. And the reason is that 2021, there is a change to this. Okay. So if your patient underwent a prostatectomy followed by external beam radiotherapy, then the primary treatment volume, since the prostate is gone, as per the STORM manual for cases 2018, 2020, we have to code it to 86, the pelvis. Okay. But if the patient did not undergo surgery and had, let's say, a low dose rate seed implant, the prostate is there, so we go ahead and code it to the prostate. Okay. And for no surgery, again, no surgery, external beam and LDR seed implants, same thing. The prostate is there, so code it to the prostate. Treatment volume, no prostatectomy, external beam radiotherapy only, and this patient may have undergone regional and a boost dose. Okay, so again, look in the treatment summary if they mention pelvis, whole pelvis, because if that is so, then the RT to the draining lymph nodes has to be coded to 06. Okay, this is indicative of lymphatics being in the irradiated field. And again, this afternoon, I'm going to show you what else you can look at to help you determine whether indeed the lymphatics are being irradiated or not. Just as a side note, it started snowing up here. Okay, if a boost dose is given, then again, notice that when a boost is given, it's such a small volume that the lymphatics are not in the field. This is why I'm telling you, anytime you see boost, just for us to help us with the coding, just think boost, no lymphatics. Moving forward, this is cases diagnosed in 2021 forward. Excuse me. So your patient underwent a prostatectomy followed by external beam radiation therapy. What we, in our discussions in revising the STORM manual and the CTR guide, again, for simplicity's sake, we decided let's just, even if the primary organ was resected, let's use the same code for primary treatment volume 2021 forward. Okay. Example, this patient had a prostatectomy, so the prostate was removed. Okay. Patient underwent a radical prostatectomy and they came in for external beam radiotherapy. Your primary treatment volume 2021 forward is going to be the prostate. Okay. So let's be clear about this change. This is a big change. Okay. And this will apply to other sites with one exception that I will go over when I get to that case. This is how it is right now for the breast. Okay, the patient underwent a lumpectomy or a partial mastectomy. So your primary treatment volume is going to be the whole breast, okay, because the whole breast is still there. Patient underwent a mastectomy or subcutaneous mastectomy. You know that what do we call it? That nipple sparing mastectomy, followed by external beam radiotherapy. Okay, well the breast is gone, so the primary treatment volume is going to be the chest wall. Okay. Electron or photon boost following a lumpectomy, to the lumpectomy cavity. Okay, well, this is a lumpectomy, so the breast is still there. So in this case, because it is a boost, it is a smaller volume. It's not going to be the whole breast. Okay, we're only boosting a small portion of the breast. So this is 41 partial breast. Notice here, I did not put a year range. This is because for 2021 forward, this is not going to change. So make a note somewhere on that slide that this pertains 2018 forward. This is the exception to that rule about the primary site remaining the same following a surgery. For example, in this case, the patient actually had a mastectomy. The breast is gone. If we were to apply the rule that I just alluded to, then clearly I would have coded this to the whole breast. But no, this is an exception. We determined that this is important information for us to continue to capture. So this is an exception to that rule. And we plan to put in some examples of this in the CTR guide. Endometrium, cervix, primary treatment volumes, okay? I notice I have a date range there too. Okay, so if the patient undergoes that TAPS procedure, I mean, everything is removed, followed by external beam radiotherapy, code to 86. If the patient undergoes that TAPS procedure followed by HDR brachytherapy, this is the code that you should be using for the brachytherapy, the boost, because we're actually inserting that brachytherapy equipment into the vagina, and so coded to 72. Now, this is going to remain the same because we're talking about a brachytherapy procedure. Okay, so 2021, this column remains the same. Okay. 2021 for this, okay, you're not going to code it to 86. You're going to code it to the primary site, regardless of the surgical resection that the patient underwent. All right, so some of the resources that I always recommend. This is a small handbook. There might actually be a new edition, so you might want to look into that. But it gives you a lot of important information about radiation therapy. We at CTR, we really need more training on radiation therapy technology. And this is the principles and practice of radiation therapy. This covers the gamut of radiation therapy. It talks about the equipment. It talks about radiobiology. I mean, it might be too much for some of us, but you can be selective from what you want to read. My suggestion is if you can get a used copy, you might be able to get it for $50 or less. I mean, the hard copy is very expensive, but this is a book, the textbook that I used to use for my students when I used to train them in radiation therapy technology. And this is free information. You might want to just copy and paste this link. And if look on the radiation oncology in general, again, it's going to give you a lot of background information on radiation therapy. And this is one of the journal articles that I contributed to the Journal of Registry Management for 2019, Understanding Radiation Therapy, a primer for tumor registrars. It's a useful introduction to radiation therapy and the complexity of radiation therapy. However, just don't expect anything on coding radiation therapy. This is just an introduction to what radiation therapy entails.
Hey,
And
Mr. Wilson, time check for you.
okay, so I'm ready for questions.
Yeah, so we have another question. So this is regarding APPA. A fellow CTR reached out to the radiation oncology from NCRA, and they said the following: APPA only is planning technique 01. If the patient had CT simulation prior to radiation, code 04 3D conformal.
The key thing is you need to determine if that patient had a 3D CT simulation. If you can make that determination, I totally agree that it will be code 04, 3D conformal. But if you look at treatment summaries, most of the treatment summaries are not going to give you that information. They're not going to tell you this patient underwent a 3D CT sim for this palliative case. But if you have access to that information, by all means, and that's one of the things that I'm going to cover this afternoon. For those of you that are lucky enough to have access to the radiation oncology database, I'm going to go over some of the things that you should be looking for that will guide you in the right direction for it's the planning technique coding that's the most difficult. The modality coding is pretty easy because for that one, you just have to know the equipment. Okay.
Awesome.
I have a question, Wilson. Okay.
Yep.
We had a patient who had airway, just one fraction, because they were afraid the airway was getting ready to close up. And then 4 months later, received primary lung radiation. So would the start treatment be that palliative to the airway and the end date be the end of the primary tumor treatment?
My initial response is on my other question. Let me think out loud. See, what I immediately think when I hear that question is that airway, was there cancer there? Because if there's no cancer, we can't count that as a phase. I would only code the radiation to a cancer site.
I think the cancer was causing the airway to compress.
You know what? Include that question. I'm going to research that further. I'm going to run it by my colleagues. Okay. So include that question in your list.
Will do. Do we have any other questions?
Oh, you guys are making it too easy for me.
This is Robin. I have a question, Wilson. Sure. If you have time to talk about it, can you discuss the rationale behind coding the tumor volume as primary site if the primary site has been surgically removed?
You know, a lot of the questions that were brought up prior to this change is why are we coding it to the pelvis? I mean, and the only thing that we can come up with is, well, it's the only thing in the store manual that approximates the region where the primary site was before the surgery. We did not think that pelvis was adequate enough a site following primary site resection. And so just to make it easier for CTRs, we thought, let's just leave the primary site code following a resection of the primary site. Let's just leave that. Because we got a lot of questions. Why are we picking the pelvis? Pelvis following prostate prostatectomy, pelvis following a cervical resection, pelvis following a uterine resection, following an ovarian cancer resection, pelvis, the same thing across the board. How does it distinguish from all of these, a variety of primary sites in the pelvis? It doesn't.
I am not seeing any more questions. Come on, people.
Here's a question. Let me ask a question. I don't know that they'll have time to respond, but how many people know what equipment your facility uses for radiation therapy delivery? And let's be frank, because I keep emphasizing that because I think it's very important, very important. I mean, as you saw in one of the slides with IORT, if you know the equipment, you will be able to code 100% of all IORT cases, 100% correctly. The modality code, the planning technique code, and the treatment volume code as well. Okay. So that's how important it is. I mean, how often do you get that 100% guarantee that you're going to code it correctly just because you become familiar with the equipment that's used at your facility? That's how critical it is. And I keep driving that home also with external beam radiotherapy, with the linear accelerator. I mean, once you know that you have a linear accelerator, you know to look at, for the modality code, you're going to be looking at O2 or O4, photons or electrons, because many, if not most, linear accelerators nowadays can treat with photons and electron modalities.
All right, we have some more questions. No XRT on site, no treatment letter sent to our incidental only facility. I guess that was just a comment. All right, the next one is radiation completed on 7/29/19 through 10/9/19. Total dose 3,400. On 8/20/19 through 10/9/19, 6x 180 per fraction, 26 fractions, 4,680 CGY right breast, FIF, I'm not sure what that is. 8/22/19 through 9/4/19, right breast, AccuDuced, 4 times 200 per 8 fraction, 1,600 CGYs. 7/29/19 through 8/9/19, right breast, AccuDuced, 4 times 340 per 10 fractions, 3,400 CGYs. Is this 3 phases with boost on 7/29 being first?
That's a lot of information. I don't want to miss something and give you something incorrect. So let me take the time and look at that question as well. The one thing that I want to comment on, you read FIF. Okay. And you even ask, what is that?
Yes.
Yes. Field in field. That's what it stands for. And in one of my slides, I wrote it down as FNF. So sometimes you see FNF, other times you see FIF. And that's the field in field technique. And in the slide where I put that FNF, I said that's one term that we use to describe 3D conformal. So see, just knowing those terms, now you know that the planning technique for that particular case is 04, 3D conformal. See, sometimes it's given to you, but not straightforward. They didn't say 3D conformal. Okay, they said FIF, field in field, synonymous with 3D conformal. But I'd like to take a look at that, and I'll be happy to respond to that question as well.
All right. Do you think we will ever see radiation treatment summaries required to be in a standard format similar to the path report PAP protocols?
Yes, I do, but not anytime soon. Okay. The two physicians that I collaborate with in putting together the CTR guide, they wrote a paper in cooperation with the COC as well, pushing for that initiative to come up with a format for the radiation oncologist department to provide us with all of the treatment information that we need in a synoptic type, CAP type format. There is an effort in pushing this, but it's going to take a while before the medical community responds. One of the things that we can do, and I have said this in previous presentations, is we need to take the initiative to educate our radiation oncology department on the codes that we're asked to capture in the abstract, because they need to be familiar with that. My initial conversations with our radiation oncologist was like, what is a phase? What are you talking about? So you have to start somewhere, because if they don't use the word phase, for example, so what they understand is plans. So one of the things that I say is, well, how many plans did you generate for that patient, for that treatment? And that is something that they'll understand. And that is something that might guide us into the total number of phases. But we need to show them, we actually need to show them what codes we're asked to capture. And maybe we can come up with our own template. If we are COC accredited, maybe that's something that can be brought up at the meetings and have everyone's input in there and support to create a template for our facilities that maybe the radiation oncologists can begin to use, so that we can encourage them to provide that information moving forward into the medical record. I work for two facilities. One of the facilities is great in that they always include the planning technique in their summary. Always, always. The other facility does not. I know where to find that information because I have access to the radiation oncology database, and I know what to look for. Again, something that I will cover this afternoon.
All right, last question. In your opinion, is it better to clarify confusing radiation scenarios with the manager of the radiation unit or the radiation therapist?
Okay, so I always encourage, if possible, to develop a rapport with the radiation oncologist. Okay, that's top. If you cannot get access to the radiation oncologist, the next in line should be, they have different terms. It could be the medical physicist or the treatment planner or / dosimetrist. Okay, treatment planner, dosimetrists are the ones that actually generate, with, of course, with the guidance of the radiation oncologist, those plans, whether they are 3D or IMRT. They will know, for example, what is the irradiator volume. They will know. They will know what technique is being used for that particular plan. So, and then if you don't have that, if you don't have access to them, then go to the radiation therapist, because in their set of instructions that they have to follow for daily treatment, they have that information as well, whether it's a 3D or whether it's IMRT or whether it's a 2D plan. And of course, they'll know the equipment.
Okay. Well, thank you so much. We'll get those confusing questions to you. I'll get Rhonda to help me with that. And it has been a pleasure. And we'll see you back at 2 o'clock this afternoon.
Great. Hopefully there'll be more questions.
Yeah.